Good morning, everybody. As Pauline's just mentioned, I'm the Development Manager for Health Education England, and I'm based in the national team up in Leeds. And we are responsible for delivering HEE's National Research and Innovation Strategy. And it's great to be here today to hear about the fantastic research and innovation work that's going on within the Thames Valley area. So I think this slide sums it up really nicely, actually. So innovation, knowledge, skills to improve lives, and research can help improve health outcomes. One of the ways that the NHS can continue to evolve is through research. And whilst as an organisation, HEE has a statutory duty and indeed a mandate from government to promote research, it is also the right thing to do in order to continue to meet the changing demands for our patients and our services. There is a growing body of evidence which suggests that research-active trusts deliver better patient care. Clinical research means patients access newer treatments faster, it can generate income, help to build trust reputation, and attract and retain the best staff. This is why investing in research is so important for HE to help bring about these changes across the NHS. And as Pauline said earlier, it's not just about the future workforce, but also, and most importantly, the current workforce as well. You've already seen this slide this morning, so I won't say too much about this one. But we published our strategy in 2014, and the aims are set up there. The strategy also included 4 objectives, one of which was to develop a multi-professional clinical academic careers framework for patient benefit. This brought together programmes that already existed for the medical and dental trainees, the Integrated Academic Training Programme, but also developed a consolidated national programme for registered nurses, midwives, allied health professionals and healthcare scientists. And in 2014, we launched the first integrated clinical academic programme with the National Institute for Health Research to help develop research leaders from these professional groups to mirror the success of the similar programmes for doctors and dentists, which have been running for a number of years beforehand. The ICA programme provides non-medical healthcare professionals the opportunity to forge the link between research and practice and make a real difference to patient care. It is those professionals on the front line who have the insight to design the research questions that really matter to them as clinicians, to their patients, to their service. And I'm really looking forward to hearing some of these projects later on today. The ICA programme is unique in that it offers clinicians the opportunity to develop their research skills while continuing their clinical duties. The ICA programme offers a pathway of schemes right from internships, and I'm really looking forward to hearing those presentations later on today, right through to the senior clinical lectureships for those experienced postdoctoral clinicians. The higher 3 levels of the programme are also supported by a mentorship scheme. I just wanted to mention some of the promotional materials that we've been working really hard to develop over the past couple of years. So you'll see some examples there, and if you aren't aware of these already, then we can make sure that you have the links circulated afterwards, and they're also on the HE website. But starting from the left, we published a special supplement with the HSJ last year, which pulled together case studies from trainees across all levels of the ICA programme, along with there's an article in there also with some chief executives from Research Active Trusts just to talk about the benefit the research has brought for their trusts. The second one from the left is a booklet which was published by the NIHR last year, I think, called Building a Research Career. Now, if you haven't already seen a copy of this, and it's a really good read, it provides a first port of call for those initial conversations between aspiring clinical academics and their managers when they would like to go and pursue a research career. We've also developed a suite of video case studies and also written case studies which are on our website and on YouTube. The chap in the middle there is Lyndon, who's one of our interns a couple of years back from the Northwest. Again, they talk about their personal research journey and what their ICA awards have meant for them. And also on the right, we've got our new magazine, which is available online, called The Researcher. We've published 2 issues of this already. It's available online. It's developed by health researchers for health researchers, and isn't the results of research or how to do research, but it's actually those personal stories, again, of what it means to be a researcher in the NHS. I'm going to wrap up there. I'll be around for the break and at lunchtime if you want to come and ask any questions, and there's some links on the screen there, but I can also make sure you get those links to those promotional materials as well, and please do share them within your networks. Thank you very much.
Thanks, Lucy. You get the gold star for going into time so beautifully and enabling us to catch up. So next we welcome Mark onto the stage. He's going to tell us about the evaluation of mobile lung function technology. Thank you, Mark.
Thank you. Right. Hello. My name's Mark. I work in the Lung Function Lab at the Royal Berks in Reading, which generally means we measure lungs. So if I can click this, can I click it? Oh, there, brilliant. Thank you. Thank you. Great. So cheers. That's the first barrier passed. So we all recognise that kind of lung disease has pretty a massive kind of impact on our lives as we live now. Millions of people living with it worldwide. Generally, treatment for lung disease is getting better, so people are living longer with lung disease. People are presenting at an older age, but we tend to be keeping people alive longer who have lung problems. So that comes with its own problems in the fact that they are perhaps more dependent on hospital transport. They may live longer with perhaps some long-term oxygen therapy. But a lot of our respiratory patients who are under specialist care, so they're under care of a respiratory physician, need regular laboratory monitoring of their lung function. And this is slightly different to perhaps like a peak flow meter that you can get over the counter, or perhaps a handheld machine. Laboratory machines are probably traditionally, they've got smaller, but traditionally probably about the size of this here, with a couple of gas cylinders connected to it, and it's kind of confined to the laboratory. So that's probably been the standard for probably about 10, 15 years now. And over the last 4 or 5 years at Reading, we've worked really hard on increasing capacity at our central site, increasing quality, but perhaps we've been a bit blinkered in the fact that we want our data to be as accurate as possible. But some of the feedback that we've been getting from patients in the fact that you're doing really well, I can get my appointments here quite easily, nothing goes wrong during the test, nothing breaks down, but I don't really want to come here anymore, in the fact that can I have it closer to my home? So our central Reading site has capture some capture GP surgery from Slough and Bracknell in the east, top of Hampshire, all the way out to kind of Hungerford in the west. So if we kind of analyse our DNA rates and our multiple reschedule rates, people from those postcodes DNA more and they reschedule more. And again, it's interesting that we were talking about patient blame as well, from an administration perspective. Well, the patient's not turned up. If I've got severe COPD, if I've got motor neurone disease, and I live in Hungerford, I'm probably not going to come to my appointment in Reading. I'm probably going to want it closer to my home. So over the last 2 years, 18 months or so, there's some new technologies that have been introduced mainly in paediatric respiratory physiology that incorporates smaller machines. Paediatric physiologists don't do well with big machines. Scare the patients, they don't get their measurements, so they miniaturise everything. So the drive has been from paediatric physiology, essentially from this. But essentially, the manufacturers, or certain manufacturers, have been able to shrink equipment that is this size down to probably, a portable television size. Before they were flat screen, before you had to kind of use 2 hands to lift them up. So we're not quite there yet. So it would be very easy. It would actually have been easier for us to buy the equipment, to put a business case together and actually go to the trust and say, buy this equipment, we need it, without actually having tested it on adults. And from an organisational point of view, it's actually quite hard to bench test equipment that we found. So certainly from my perspective, if my head was going to be on the line and we were going to spend £30,000 of actually charitable funds that patients have actually put money in the pot for, rather than government money, I want to be sure that we are going to buy equipment that serves our patients right. And from experience, not necessarily the trust that I work at now, it's very easy to buy kit on a whim, at a conference. It's a good offer, and you get it back in the lab and it's thinking, it's not actually quite as good as we thought it was. So we wanted to make sure if we were going to go down this road and start to use mobile equipment at different sites closer to people's homes, we wanted to make sure that the equipment was going to work. It's relatively easy for a consultant to set up a mobile clinic. They just need a room, a nurse, some sort of administration. For us, very hard, you know. So we wanted to be sure before we went down this road that the equipment that we were thinking of getting is going to work for us. So we mail-shotted patients. We wanted the patients to be involved. The feedback from the patients sound, you know, I really like this test closer to home. So we used that to our advantage. So we mail-shotted some of our patients in those postcodes and say, we want to do this, please be involved. When you come to your next appointment at the central site, would you be willing to do some extra tests? And amazingly, they were. So we got a group of 62 patients, and I'm not going to blind you with the physiology parameters really, but we wanted them mixed up. So aside from it would be very easy to get like a normally distributed group, but we wanted patients who were very obstructed, so you're maybe severe COPD patients, and what we would term as very restricted, as in fibrotic patients, people with neuromuscular disease, but also people who have efficient lungs with a relatively good TLCO, a gas exchange, and people with poor gas exchange, emphysema, that kind of thing. So we want to kind of mix our kind of range up. And it was basically just a simple repeated measures. They came to the lab to do their routine clinical appointment, and at certain points in time, we asked them to do certain tests on our new kit that we brought in for a couple of months of bench testing. So results are actually very good. And again, aside from when we perhaps normally test things statistically, we didn't really want any significant difference between these machines, you know? So our main parameters are the airway, FEV1, very small difference between those two. Gas exchange, slight negative offset, but within clinical kind of variability of, say, daily variation, you know? We only found one difference in the fact of actually in-peak flow. So the mobile technology actually measures a slightly higher peak flow from the same patient compared to our laboratory kit. Mainly, we think, because of the way it measures flow. There's no filter that you blow through because the technology as such is that the patient's breath doesn't touch the equipment in itself, so there's no real infection control issues there. Lovely. So, from a patient care perspective, we've responded to patients' requirements. We've moved their care provision into the right place, so they can have, you know, from the front end, they can have a diagnosis, but then they also have a plan to say, okay, I want my lung function tests at Newbury, at Bracknell, at Henley, kind of thing. And actually, from a really positive perspective, it's allowed patients to be involved in changes in their own department. Some of our patients have been around for 20 or 30 years coming to us, so they see people come and go, they see rooms built, rooms taken down, that kind of thing. So it's really useful for them to see and help us improve our service for them, you know. For me personally, it's a really good introduction to independent research of a problem that we find day to day, and not just saying, right, I want to do a bit of research, I'm going to look at a set of titles and see what applies to me. And, you know, it gives us a very good, actually, kind of a bit of power to say when we actually buy equipment, you know. And actually, I mean, none of my intern group are here today, but it was actually really useful, sat in a room with different professions, paramedics, pharmacists, physiotherapists, you know, of the similar grade to myself, and actually we have very, you know, similar problems and similar things that we want to get done, you know. So lastly, mainly from a trust perspective, they've said yes, we've actually bought equipment now, and we start our clinical measurements in satellite clinics next month, January should I say, it's not quite December yet. And some of the feedback that we were able to give to our manufacturers is really useful from their perspective, because some of their feedback to us was that it's very hard for them to get information on real-world patients. They can test in their own laboratories and say this equipment is fit for use, but it's actually very hard for them to get feedback when it starts getting put into use as well. Thanks for listening.
Thanks, Mark. That was a great example of the benefits, not only for patients, but also for you as a researcher. And also something that really is bringing care closer to home. So that was a really nice elevator pitch and a great example of the impact that your work is making. So any questions for Mark? I'm sure you could take one question. We'll let you have one question. We're going to have questions. We're going to have questions at the end. Sorry, my mistake. So next we welcome NIHR. I said that. Excellent. And you're going to tell us about your evaluation study around antifungal prophylactic approaches in high-risk haematology patients. Thank you.
Thank you. My name is NIHR. I'm a lead pharmacist, haematology pharmacist at the Churchill Cancer Centre at Oxford Hospitals. I'm going to talk about the particular high-risk haematology patients. So they tend to be patients with acute myeloid leukemias, myelodysplastic syndrome, and patients who have transplantation for hematological malignancy. And my talk is going to focus on the use of antifungals to prevent and treat fungal infections. So, like I said, these patients are particularly at high risk of having an invasive fungal infections during their hospital stay, during their treatment. Two particular species are the most common. They account for 95% of all the cases. They're Aspergillus and Candida. They are associated with a high risk of morbidity and mortality, and the studies have shown that 49% of the patients who are on chemotherapy for hematological malignancy and who have an invasive fungal infection would die, and that rate can go up to 86% of patients who have transplantation. In practice, this is managed mainly by giving these patients antifungal prophylaxis, and then if they develop signs of the fungal infection, they will get either empirical or preemptive treatments. This is associated with a huge economic burden. A UK study has shown that the management of someone in a UK setting has shown that managing someone with a fungal infection can cost up to £88,000 per patient. And the cost of the antifungal agents themselves is huge, and in the last year within OUH we've spent about 1.5 million on these drugs. So with that in mind, we thought we'd really quite like to know how we're doing with using these treatments in preventing and treating patients with invasive fungal infections. The aim of the study is to look at the medium duration of prophylaxis. Are we overusing these treatments or are we underusing them? What is the impact on patients? What is the, particularly looking at mortality, which is the all-cause mortality and the mortality that is related to fungal infections. And then we've spent a lot of money on preventing those infections, and how many of patients then had or were then following on that were treated for invasive fungal infections. So looking at the percentage of patients, and when we've treated them, how long have we treated them for, again looking at the resources. So retrospectively, we've pulled the data for about 118 patients within the high risk category, so we've mainly used prescribing databases for chemotherapy and antifungal and dispensing systems. So table 1, I don't know whether you can see it very well. The poster is right at the end, so you could see the poster for further details. I'll try and summarise on the slides. And we've used descriptive analysis to look at those endpoints. So the results have shown that patients were on antifungal prophylaxis for a median duration of 60 days, and that fits in with the period of neutropenia, and because patients would have 1 or 2 cycles or more of chemotherapy, and if they have transplantation, they have probably a median duration of neutropenia of 21 days. So that kind of showed us that we are, our use of prophylaxis and the duration is probably optimum, and there's nothing to worry about in that sense. Posaconazole is one of the agents that we use mainly to prevent a type of infection, fungal infections, mold active infections. It is our first line in our local guideline. It's very expensive. And we looked like the highest duration was about 70 to 60 days in patients with acute myeloid leukemias and GVHD. GVHD is when patients have transplantation. It's when the new cells kind of attack your own immune system, and that makes you at high risk. So again, the duration in those two patient groups was between 60 and 70 days, and that was in line with national and international guidelines. So again, we're quite happy with that as well. And when we looked at the treatment, we found that half of the patients who were on prophylaxis, 46%, were then treated for a suspected invasive fungal infection. And the treatment duration, we treated them for a median duration of about 15 days. The mortality, we looked at 180-day mortality, which is a kind of a standard endpoint that studies will look at. We found that a third of the patients in the population have died, and that could be related to either disease progression, relapse, or complications from the treatment from the disease itself. Then we wanted to narrow down to how are we going to find out from these third of patients those who could have died with an invasive fungal infection. And we found that 11% of the patients have died whilst receiving treatment for invasive fungal infection. And that's when it gets a bit tricky, because we don't know 100% whether they actually had an invasive fungal infection or whether we were treating them empirically. So future work we would need to look at the resources within our own hospital. We know how much the drug costs. We also need to look at how much the inpatient stay, all the resources are costing for these patients. But the most important takeaway, I think, from this project is to try and improve on our diagnostic strategies. 11% of patients have died whilst on treatment, but we still don't know whether they actually had that infection, because our the current diagnostic criteria are not standardized. We're not doing currently routine diagnostics for those patients. It's an area that we probably need to go away and collaborate between microbiology and hematology to try and improve on that aspect. So future work will focus on that, and hopefully maybe liaise with other centres nationally who are doing that sort of diagnostics to try and kind of direct the treatment strategies better. It's likely that we're going to change. I mentioned posaconazole, which we're using as a first line, and as a cost improvement project, a new drug has come off patent. We might then switch to using that, and we would like to repeat the same similar project to kind of look at what's changing practice, what it would bring to patients. Ideally, once we've kind of optimized our diagnostics, we would need to repeat and do a prospective, properly powered study, and employing those diagnostic strategies to define the exact incidence of those invasive fungal infections. So throughout this process, there's been a lot of learning, research skills through the internship program, basic research skills, how to formulate a question, data collections and analysis, as well as specialist skills I've learned in terms of how the specialist antifungal management of these hematology patients, and that would allow me to contribute successfully to the next guideline update. Patient care and organisation, that has initiated a lot of talks within the department and planning for future work, and hopefully that would result in us using our resources efficiently and try and preventing these patients from having these infections, multidisciplinary collaboration, as well as kind of bringing that culture, research culture of pharmacists working collaboratively with the doctors and to develop a research-focused workforce within our department. Professionally, has empowered me to embark on this early journey of a clinical academic career. It helped me identify we've had very good sessions on research skills, after which, and through this project, I have identified my own learning needs and gaps in research, and identifying kind of what sort of future opportunities for putting in applications for bursaries, doing research modules and courses, and hopefully support for master's applications as well as collaborative working. That's the references, and thank you. I'm going to now hand over to Anna, who's been a fantastic peer. We've supported and held each other's hands through this early steps, didn't we, Anna? Thank you very much.
Welcome, Anna, but before we introduce you, just to say thank you for that presentation. Another really nice example of the personal and professional impact of that programme. And I think, too, to summarise what you said, how important it is to direct the treatment strategies in terms of the potential economic and cost benefits, which we know are really important because we need to save money to reinvest back into patient care. So thank you, it's a really great presentation. So now we welcome Anna Marie, who's a midwife from Milton Keynes, and you're going to talk to us about the experience and views of midwives using fresh ears.
Yes.
All ears.
Thank you very much indeed. Hello everyone, my name's Anna. I am a midwife and I currently lead the home birth team at Milton Keynes, and we launched successfully yesterday, so I've come hot from that to this. So thank you for listening. So I want to introduce you to a concept called fresh ears, which is something that was introduced for our trust off the back of a number of incidents which, whilst not exclusive to our trust, we recognised that there were gaps in practice, that we needed to be able to demonstrate that our practice was robust and it was safe and it was valuable for the women. So the aims and objectives of my project was to look at midwives' views and experiences of using this particular intervention, which I'll discuss in a second, and how they felt that impacted on their practice and actually the women. I have a real passion for qualitative research. I feel that it's not valued in the way that it should be. It's lovely manipulating numbers and be able to say that, look, we've improved it by X%. But actually, if we don't know how essentially the women and the midwives are experiencing particular interventions, then I think that leaves a really big gap. So that's why I focused on looking at experiences and views. So in 2015-16, we had around just under 4,000 deliveries of live infants at Milton Keynes Hospital, which doesn't seem like a lot in comparison to other trusts, but actually, you know, that's a lot for us. NICE recommends that we should be, and this is absolutely the crux of our practice, intermittently auscultating every 15 minutes in labour. So for a low-risk labourer, we'll listen to the fetal heart rate every 15 minutes for a full minute immediately after a contraction. And there's a range within which that fetal heart rate should sit, and we plot that on a partogram so that it's a very simple means of identifying if that heart rate is deviating from the normal so that we can escalate appropriately. We've identified that that may not have been undertaken in the most appropriate way within the trust. So we introduced a concept of fresh ears. So any of you that have had a baby, if you were high risk, you would have had electronic fetal monitoring, so continuous monitoring in labour. We know from the research from that if you don't look at that trace and you don't reevaluate it with a pair of fresh eyes, you can miss things, particularly at 3 o'clock in the morning. It's not a practice that we've transposed over to intermittent auscultation. So what happens now is if we're undertaking intermittent auscultation, every hour another practitioner will come into that labour room and they will time that minute. They're not listening necessarily for deviations. What they're doing is timing that minute. The aim of the project really was to identify how midwives felt about that, because there was a huge amount of resistance initially because it wasn't evidence-based. But the argument was actually not everything is evidence-based at the beginning, and it's an innovation that potentially could save babies' lives. So we looked at sending a number of questionnaires out to all the midwives. So we used purposive sampling to send all questions out to all the midwives within the trust, comprising 15 open-ended questions. I did pull data in terms of banding, length of experience, etc., so that we could see whether or not there was any correlation with that and the themes that emerged. And we, having sent them to 153 midwives, had 13 responses, which isn't a lot, but that's great for me. I'm more than happy with that. We actually had to whittle that down to 11, because one of the inclusion criteria was that they would have had to have practiced low-risk intrapartum care, and 2 of them hadn't, so off they went. So I had 11 good responses. The emergent themes that came out of it were quite interesting. Firstly, confusion around the purpose of fresh ears. When it was introduced, there may not have been enough information to substantiate why we were doing it. The sorts of things that were coming back were that they're coming and checking on the midwives. Are we doing our job properly? When that actually wasn't the purpose of it. The one that really worried people was the effect on their labour, the effect on women's labour. We know that for women to labour comfortably and effectively, they need to feel safe. They need to ensure that they have the opportunity for hormones to be working in the way that they should be. And having other people coming into the room, sitting with, tapping on their clocks, are they making sure that they're timing for a minute, potentially could affect that woman's experience of labour. But ultimately, what we were finding is that people were making comments on whether or not it was improving the safety of the woman and the fetus. We can't prove that at the moment, but this will be the basis for a bigger piece of research undertaken with me, the research midwife, and the consultant midwife, to actually look at the efficacy of this particular intervention. How does that apply to us then? We will be undertaking further research as part of this. We've had long conversations about whether or not, how we can go about it. And we're not quite sure how we get there yet, but it's opened up those conversations. Interestingly, when we drilled down into the figures in terms of who actually does like the intervention and whether they felt it supported their practice, we found that Band 5s and recently qualified midwives loved it, which is really interesting because the rationale behind that sort of tells us that these are the methods of support we should be putting in place for preceptors. So there's a lot more work to be done there. The Trust is retaining the practice and it's being embedded into guidelines, but we just need to be able to substantiate it. And we're hoping to write a paper to then disseminate to the rest of the UK to see whether or not it's of benefit to everybody. Ultimately, our aims are to enhance patient safety and challenge preconceptions of care. We know we came across resistance to the practice, but actually, in doing this, it's opened up conversations within the teams as well. They hadn't actually considered it from the points of view that we were asking them to. The internship's been amazing, I have to say. It's been my first opportunity to undertake any type of research. I've always had that passion there, and I've always wanted to do, go into academia and not really known how to get into it as a midwife. As a result of this internship, I've now started my master's at Oxford University into evidence-based healthcare, which I'm very grateful because I was awarded a fellowship for that. And I absolutely thank this opportunity and the internship opportunity for what they've done to help me get to that point. Because I hope to continue to be able to really help these women and get their voices heard, and midwives get their voices heard. So, yeah, that's it. Thank you.
Thank thank you, Anne-Marie. I do like a bit of qualitative research. That's a really interesting one because for me, that's kind of piqued my interest because I thought, oh my goodness, there's a lot more questions there. There's something about the culture of midwives, there's something about the socialisation of midwives, there's something about that research question that you've unearthed. So I think that's really, really interesting. So well done and good luck in terms of your next steps with that. So now do we take a few questions now on this particular phase of what we see? So happy to have any questions to our presenters. Oh, excellent. Do you need a mic or?
I think I'll probably be okay. This is a question for Anne-Marie. Hi, my name's Louise Perkins.
Hi, Louise. I know you.
Training practitioners in midwifery. I just had a question. I wanted to first congratulate you for implementing the home birth team in Milton Keynes. That's really exciting.
Thank you.
I was just wanting to ask a practical question on how you're doing fresh ears in the home setting.
Yeah, that's a really interesting one actually. It's a good question. It depends. It depends what sort of labour we're having, because at the moment if we have a birth in labour or labour in water, then we always have 2 midwives there. At the moment we're not actually able to provide fresh ears at home otherwise. So that again is another question that's been drawn out of this and as part of the fetal monitoring guideline, because we just can't at the moment. So it's a good question. Sorry, I've got no answer.
Any other questions? Beth?
I'd like to ask Mark a question. I'm fascinated by spread because these are beautiful projects. You've all done really well to present so well this morning, but it's about how we then start to make these things happen. And I'm just interested, Mark, how have your commissioners embraced your closer to home piece, which is beautiful and completely person-centred, but actually so often it's the commissioning that then gets in the way of this and will stop the spread of what is genius.
Yeah, I mean, they've been actually, it's been really positive.
Good.
Although the purchase of the actual kit itself we've made out of charitable funds, the CCG have given us more staff.
Brilliant.
So obviously staff will go through that machine and we need staff to backfill our central site. So we interview tomorrow, basically.
Fantastic. And how did you make the CCG? Did you have those conversations from the outset? Is that just something that you responded to?
And I think, just without this process, we wouldn't have been able to bench test the kit. It would all have been theory-based. Actually, we want to buy this kit, but we don't know if it works. We don't know if the actual process is going to work. Are we putting our patient data at risk if we do this? So we can actually we went to the CCG and said, we know that this works within this capacity, let's go for it.
So this unlocked that conversation for you?
Yeah, it's great.
Beautiful, thank you.
I guess my question is, how do we get these stories, these messages about the difference you guys are making out to our patients? Because there's been a bit of technical language, and of course there has, because there needs to be, because you were presenting, data. But there's some really powerful messages out, isn't there, to how this work makes a difference to me as a patient or me as a user of services. So we need to, and I suspect that will be a thread that runs throughout today really, and it's very important to think, okay, where do we take this next in terms of talking to our patients and service users about the impact of this kind of work? So we need to think about how we do that as well. Any other questions for the presenters?
May I ask Deborah a question? Without going into the minutiae of all the narratives of your patients that you questioned, I'm just, as a registered district nurse, I'm mortified that a patient would have 4 services going in and someone slapping a bit of gauze on, because my speciality was wound management. So the moral issues around that, do you have to refer on and find out what's happening, or do you just take it as it is?
The services that they're using are different than normal nursing services. So one of the issues, and again, I'm mindful of time, is that these people with this problem, they lose their mobility, they lose their independence, they lose their enjoyment of life, so they get depressed and anxious, so they're often then others coming into the home that might be there to help them with a bit of cleaning, or but there's still services provided by the taxpayer.
Yes.
So the services aren't all nursing services
No,
or all direct care, but they are services designed to maintain them in their homes.
I think if anything it points to the necessity of the integrated care model that we're working towards at the moment, and how we need to match it all up, because that really, really worries me.
That's the team we're working with on this, actually, is the integrated care team on the projects.
Right.
Yeah.
You know, I'm with Deborah on this one. Just having celebrated 40 years in nursing, and you know, we're still asking the same questions about pressure sores and moving patients and treatments, and we still haven't cracked it. So, yeah, that's our experience. Douglas.
Just a quick one. I'm really excited by a lot of the research that I've both seen and heard so far. But one of the things I really want to just implore you to do is to think about research into practice. Because practice doesn't need to follow research. Research and practice can go together. And one of the things that you hear a lot of at the moment is co-production. And I think a lot of people mix up the two words of consultation and involvement. And I think the earlier you involve a patient in the research that you're doing, the better your results will be.
Yeah, it's a good note to finish. Thank you, Douglas.